This is the anemia map of the world from the WHO database on anemia. If we look at the countries with red, deep red, where almost the whole of Africa is involved, and the southern part of America, these are countries with severe anemia. But it is good to say that anemia is available everywhere, except in North America, in Alaska, where almost everyone is having a normal blood level, as it were, hemoglobin level, as it were. But it's also good to say that without physiological adaptations, the countries with red, maybe everyone there would have been extincted by now, and then the countries with just a slight tinge of red would have been real red. But because of adaptations, that's why these people, I would say, are people in countries where you have this severe anemia in almost the entire population. Next slide, please. Okay. My definitions. The definition of anemia could be as functional, defined as insufficient red blood mass to adequately deliver oxygen to the peripheral tissues. And for the measurement of anemias, hemoglobin levels per gram deciliter is usually acceptable. Hematocrit is what is measured by the Coulter counter compared to the packed cell volume. Hematocrit measures the red cell mass, and then there's some calculation that goes into the machine that brings us and gives us our hematocrit. Whereas packed cell volume is a mechanical device with a lot of things that makes it not to give us adequate or accurate result. For instance, if you look at the diagram exposed here, where you have the red, it's supposed to be where red cells have been packed. But it doesn't tell us the percentage of plasma that's also been trapped in spite of the spinning, or even the number of platelets that have been trapped or white cells have been trapped in spite of the spinning, thereby giving us a relatively higher value compared to what we usually have in the calculated one by the automated machine. The red cell mass also gives us a fair idea of the anemia and what is happening in the marrow. Next slide, please. When we talk of anemia and want to use it for clinical use, the age of the patient comes into play. For instance, for neonates, for infants and children, their levels of hemoglobin are actually different from adults, and they're also different from that of adults, is also different from those from 80 years and above. There are sex variations, of which women in the reproductive cycle have a necessarily different kind of scenario that will help us to make clinical judgment. And of course, pregnancy, if it's going to be, when we are going to compare pregnancies and anemia, we have to look at a different scenario entirely. How well hydrated is the patient? Is our hospital where we are considering our patients at sea level or at a very high altitude? All this will have to be taken not only also in the history, but in interpreting the result when we want to talk about the hemoglobin levels and also talking about anemia with regards to clinical intervention. Same thing with other hemoglobin abnormalities like thalassemia, which we are going to consider. Next slide, please. So I talked about adaptations. Physiological adaptations in the human body could be defined as a metabolic or physiological adjustment within the cell or the tissue or an organism in response to an environmental stimulus that will lead to an improved ability for the organism to survive or cope with the changing environment, enabling it to survive. So physiological adaptations is generally narrow in scope and involves a response of an individual to a particular and usually narrow range. For instance, low oxygen tension in the blood is a stimulus, and the body responds appropriately to address that. We're going to see other examples, like in polycythemic patients, yes, high hemoglobin level in people who snore or chronic cigarette smokers. These are all adaptations because someone who snores and gets to apneic attack several times in a year, he would have stayed without breathing or taking in oxygen for up to a day or two, as it were. And the body tries to respond to cope with that by producing more red cells in order to catch up the available and to start to make the patient survive. Certainly with cigarette smokers and other people who have very hemoglobin with high oxygen affinity, they also have high polycythemia, secondary polycythemia as it were. Almost every organism. That's why even cancer cells adapt to environment by neovascularization and diegenesis in order to survive the harsh environment that is operating. Dark-skinned people living around the equatorial belt, as a result, it's all adaptations. Bacterial resistance to antimicrobials, tanning of skin, even development of callus due to repeated pressures are all adaptations. Indeed, it might be safe to say that all species won't get its life must be capable of adaptive changes to survive a rapidly changing environment, without which it might be difficult for anyone to survive. In our current talk, we are going to talk about when exposed to low oxygen tension in tissue due to anemia, what adaptive changes does the body make? Next slide, please. So we talk about the levels whereby people want to transfuse, and they talk about the threshold hemoglobin, critical hemoglobin, and they give it, and we have a number. That about 20-something years ago, WHO came out with the Haematology toxicity scale. We have for other clinical chemistry, which is very interesting because it doesn't just give us one value, it gives us a range because the patient does not just come down with one value. Depending on where the patient presents, it could be at grade 1, grade 2, grade 3, or grade 4 toxicity according to this scale. Whatever it is safe to say that grade 1 is mild anemia, grades 1, 2, and 3 is moderate, and of course, grade 4 is very severe anemia. If you look at different countries and different hospitals, like in the United States, for instance, some use grade 4 here is we have 7 grams per DL. Some use 7.5 per DL. Some use 6. Mayo Hospital, for instance, they use 6.5 grams per DL as their severe anemia cutoff point. Provided to say that it might be safe to have this scale to be able to use in making clinical judgment with regards to intervention. Next slide, please. But in malaria area or belt, as we have, that scale may not fit in so well. So that severe anemia in malaria or endemic area is brought down to 5 grams per DL, and moderate anemia is 8 grams per DL, as it were. So that one will not normally rush to take a rather very drastic intervention when you have 5 grams per DL. In malarious area, this is usually something that we see very often. Next slide, please. So when we want to talk about anemia, we can broadly group them to surgical anemias or blood loss, surgical, which would be intentional, like in all surgical interventions, or non-intentional, like in accidents and trauma. What do we do? In most of the advances made in patient blood management, a lot has been done and achieved in this area of management of patients without response to blood transfusion. Whereas medical anemias, which could be shortage due to non or inadequate production by the marrow, or it could be due to adequate production but rapidly destroyed as hemolytic anemias and other anemias where there is a rapid destruction in the reticuloendothelial systems. What is the body's response, and how do we understand this response with regards to making adequate clinical judgment in order to help the patient, with especially those who are presenting without any option for transfusion? Next slide, please. So the body makes adequate response immediately there is an injury. Please, can we go down? Next slide. Good. So immediately there is an injury or a definitive intentional cut, for instance, the body has a very vast array of adaptations. In a vascular breach, as it occurs, the platelet plug that occurs is the primary thing that occurs in order to stop bleeding. But there is something that precedes that, and that's the vascular spasm that narrows the vessel just to reduce hemorrhage. So the heart rate, the body responds by increasing the heart rate. How does it do this? In order to increase cardiac output, heart rate, stroke volume is increased, heart rate is increased in order to make sure the patient, the tissues are perfused in spite of the anemic challenge. But if this is not attended to quickly, other sets of compensatory mechanisms will set in. Next slide. Next. Okay. So there's a large physiological reserve that helps in this. Bruce talked about it on Monday, and now Chimaobi has talked about oxygen distribution curves. I'm not going to dwell more on it. Suffice to say that it is an efficient method that helps the body to deliver oxygen effectively to the tissues. Without that property of the oxygen, it would have been difficult if it was just a plastic kind of molecule that holds onto oxygen, so that the more it is able to release oxygen to the tissues, the more the tissues will be oxygenated, as it were. So this is a property that has found usefulness in the understanding in helping us to be able to manage patients adequately, especially those that have lost so much blood, as it were. We could manipulate the temperature, we could manipulate and make sure that the pH is right and things like that, just to help tissue oxygenation. Next slide, please. So let's go to the first set of causative agents for anemia, the commonest of which is iron and leading to iron deficient states. Iron is a rate-limiting molecule in hemopoiesis, or in red cell to be very specific. That is, as the molecules are being assembled to make hemoglobin in erythropoiesis, of course, we know that different globin chains are being coded for by different sections of the DNA of the genome. So as they are being assembled, iron is the last molecule to add it to the hemoglobin for it to be a complete functional molecule, as it were, capable of performing its functions. So when iron is in lack, the cells continue to divide. Reason being that the right complement of hemoglobin is not being made. It is this amount of hemoglobin in the cytoplasm that limits the cell size, as it were. As more hemoglobin is made, the cell goes enough will have enough. So the cell stays. But if there's no hemoglobin, the cell will continue to divide and divide. So there's increase in mitosis, leading to very small red cells. So patients can present moderate to severe anemia due to iron deficiency. So the patient will usually present with iron deficient state to iron deficiency anemia. By the time a patient presents with the anemia or even more severe anemia, it is likely that the bone and the iron stores in the reticular endothelial system, specifically in the marrow, is depleted. If you look at the micrograph here, this is what the cells look like when the blood is deficient, is produced without iron. You can see the pale area is without hemoglobin. So you see, majority of the cells here are expressing that kind of morphology. They are pale because there's no hemoglobin being made. This is what we see in iron deficiency states. It clinically presents in different forms because iron deficiency or iron as a molecule itself is used in different metabolic and processes, including enzymatic actions in the body, so that chronically the patient can come with a beefy tongue. It looks very smooth due to absence of papillae, apart from the fact that it's going to look pale. It looks very smooth and shiny, as you see in this. Then you can have the spoon-shaped nails as well. But it is very, very amazing what we see when we go into the marrow to look at it, to look at what is happening. Yes. So in a normal marrow, you could see when it is stained by pushing blue, this is what it looks like. But in a patient to be iron deficient, it will look like this, even after it has been stained with pushing blue. There's no iron stores left. At this level, it is assumed that since you may not go into the marrow in all patients, when you look at the MCHC, which is usually the last drop in your red cell indices, MCH will drop, MCV will drop, MCH will drop. The last to drop will be MCHC. When that begins to show some abnormality, it's likely when you do the marrow and stain, you're likely going to have a depleted marrow, as you see in this micrograph. So having said this, what would be best to replace in this patient? Is it blood or iron? So time for clinical decision making in iron deficiency anemia. What will you do? Will you transfuse or will you opt for patient blood management? Look for the cause of the problem and then address it adequately. Next slide, please. So hemolysis, next slide, please. So hemolytic anemias, which could be acute or chronic, and the acute hemolytic anemias are numerous. The chronic ones could be inherited or they could be acquired. But whatever happens is that if you do a bone marrow aspiration or bone marrow biopsy as well, you are going to see that everything is actually normal, except that there will be hyperplasia of the red cell precursors. That is, they are large in number, ready, and produce even more than usual as well. Now, next slide, please. So there are many things we are going to see in hemolytic states. And there are so many kinds of hemolytic anemias, as we are going to see some of them in the course of this presentation. But there is some surrogate to looking at the marrow, and that is the reticulocyte, that's the young red cells. And there are so many manipulations of reticulocyte information now that helps us to really interpret what is happening in the marrow. Whatever happens, if a patient's reticulocyte is far way higher than what is observed in that environment, it means the marrow is adequately responding to the anemic state. In other words, the problem is not with the marrow, it's producing adequately, but something is destroying the red cells that are being produced. So it becomes something that helps us to decide if the body is producing red cells and we and the body is destroying, what will happen to any red cell added by transfusion? Will it last? Will it stay? Will it survive whatever injury that's causing the hemolysis? Your answer, your guess is as good as mine. So in almost all hemolytic states, you definitely have no room for transfusion because it will not be helpful, as you're going to see in the course of this presentation. Next slide, please. So let us look at one of them, spherocytes. That is cells that are smaller in size. They are globular and spherical. There are many injuries to the body that can lead to this kind of scenario as we've seen in this cell. Some of them are inherited, some of them are acquired. Next slide. So in the inherited form, though you may not come across so many, one of the regular features you're going to see is increased reticulocyte count, up to 20% in some patients. Once we see this, looking at the peripheral cells will help us to identify them. And once we do that, it is easy to find out what the cause of the problems are. If it is inherited, we will see. If it is not, we're going to see. But spherocyte will definitely be seen, and the percentage number of spherical looking cells in the peripheral field will be quite higher than what should be for the normal population. Next slide. So the morphology and things associated with it is recorded here. Next slide. Coombs test will be negative. Next slide. So the other problem is the G6PD deficiency. Of course, the patient can be well throughout if he is not exposed to medications that will injure or tamper with the cell membranes as well. But once the reticulocytes begin to respond, the patient begins to recover. When the reticulocyte count responds adequately, and of course, newer red cells are rich with the enzymes, so they'll be able to cope even with the drug that instigated the problem that led to the anemia. If the drug is given at the same dose, they only become to be injured if the dose is increased, as it were. Next slide. So in this group of patients, reticulocytes is good to measure. Haptoglobin will be totally absent as it were if it is measured, because all available hemoglobin has been mopped up by haptoglobin. So you measure that molecule, you will not find it at all. You'll be able to assay it. Next slide. So, okay, this slide should have come before that. That is hemolytic anemias, either extravascular or intravascular, as it were. If it is intravascular, haptoglobin is going to be absent. The extravascular anemia, hemolytic anemias, haptoglobin is going to be either normal, as it were. Now, we're going to see some of this occurrence when it comes to hemolytic anemias in different forms, as we're going to see in sickle cell. Next slide. So what will you do in hemolytic anemias? Will you transfuse, or you will opt for patient blood management? If it is in drugs that are instigating the hemolysis, our clinical history will help us. And we want to look at the instigating factors and arrest it, and of course, the patient will recover. Next slide. This patient was transfused 21 pints of blood. And the patient gave a history that after each transfusion, 2 days after, it looks like the weight in her abdomen becomes heavier. Before the patient was referred to us, and we opted that the patient should have the spleen removed. Of course, patients with enlarged spleen may not have to be as large as this. This spleen actually weighed 4.2 kilograms at the time it was removed from the patient. Of course, most of what is increased is red cells that have been trapped in the splenic sinusoid. But it's good to note that in a clinical examination, if a patient has an enlarged spleen, we have to be worried, and we should be able to take that into consideration in regards to interpreting the anemic state that the patient may be presenting with. Of course, when the spleen was removed in this patient, the patient recovered fully, even had a baby after that, and has not had any need to be transfused by anybody at all. Next slide. So, could your patient be having hypersplenism, which is a syndrome, in my opinion, that comprises having an enlarged spleen, may not be like the one we've just seen, and will have a reduction in red cell, white cell, and platelet population in the blood, and also this decreased survival. There's a decrease in the survival of red cell and platelet in hyper, because these are being destroyed in the spleen. And to make a diagnosis of this, if a marrow is done, you see that the 3 cell lines are actually increased in the marrow. And if the spleen is removed, there's an improvement and even a reversal to normal state. Would patients with hypersplenism benefit from transfusion? Your answer is as good as mine. Next slide, please. Good. So in sickle cell state, we know what the pathology is. Due to adaptation to malaria, the hemoglobin gene had to go this adaptation in order to produce hemoglobin AS. And the bystanders are the ones that now have the SS. But even the SS makes an attempt to survive. Next slide. And what is this adaptive change that takes place? The circulation of the patient with sickle cell anemia would definitely hemolyze, and the cells are destroyed to a level where the plasma is enough to make the blood less viscous. That is why, from our own experience, you transfuse a patient today with sickle cell anemia, the next 2 days or thereabout, everything will be destroyed and to still come back to the steady state hemoglobin the patient came down with. The patient will look a lot better initially at transport. It will still drop to that level after a short while. Why? The patient is better adapted to having been in anemic state. In that state, the plasma is more and the blood is better able to flow, because any reduction in flow or hyperviscosity, as will be produced by either hypertransfusion as is done in some areas or in some practice or in some complications, then the blood viscosity will encourage cell-to-cell adhesions and injuries will take place, and stasis will also lead to cells being sickling, as it were, leading to a worsening of the situation. The greatest beneficiaries of this adaptation are people with hemoglobin AS, who can stay almost throughout their lifetime without having malaria, or if they have, it will be very, very mild. Next slide. So we benefit from this information by observing the steady state hemoglobin of patients, and it guides clinicians in patient blood management. For instance, a patient that will have this, been able to derive the steady state, and they say hemoglobin is about, say, 8 grams or even 7 grams. If it comes down with 6 grams, we're not going to rush to transfuse because of the change between 7 and 6, or between 8 and 7, depending on what the steady state is, because the patient has developed adaptations around that level to live a normal life. We also have seen a correlation between the number of irreversibly sickle erythrocytes and the clinical state of the patient. And people have said that using pulse oximeter, you are not going to get any correct value with regards to tissue saturation in patients who are living with this condition. But people have done work and they found out, no, that people with sickle cell anemia, actually, when their tissue oxygenation is measured in pulse oximeter, it is fairly accurate. And this can be used to be able to manage them using the patient blood management method instead of just hypertransfusion or double transfusion. Next slide, please. Next slide. So, would you transfuse every patient that comes with different complications, or you opt for patient blood management? Next slide. The thalassaemic syndromes are a different thing entirely in that they come down with the cells are there, but they don't have the right complement of the globin chain or the right complement of hemoglobin that can pick up red cell, that oxygen as it were. And they are chronically hypoxic. And because they are chronically hypoxic, the body stimulates more cells to be made, and they are also being destroyed. In this state, in thalassaemic patients, it becomes difficult to manage, as it were, except some that are not even compatible with life, where there's absence of any kind of hemoglobin at all that is functional. Those ones are not compatible with life. But the ones that are compatible with life, especially in the Mediterranean region, a lot has been done in caring for this cohort of patients. Next slide. So, okay, we've done this already. Next slide, please. Let's look at pregnancy, pregnant state. I put anemia in pregnancy in coma because some people believe it is not actually anemia. It's a physiologic drop in hemoglobin level. Why? Because in a normal pregnancy state, what happens is that there is plasma expansion leading to huge dilution, as it were, starting from the first trimester. And this drops the hemoglobin drops, and the fat cell volume drops, the hematocrit drops as well. But there is also, especially from the second trimester, an increase of the red cell mass. But the increase in red cell mass lags behind the plasma expansion. This plasma expansion or dilution of the blood, as it were, is a very fine condition to a normal pregnancy. Where it does not occur, there's something wrong with the pregnancy. As we can see that in some patients that come with very high hematocrit in pregnancy, many times it is due to poor plasma expansion. Some of them can be seen in the preeclamptic state, and the implantation has not been correctly done, as it were. And preeclamptic state will occur, and there's going to be problem either for the child or for the mother, either for the fetus or the mother, or both, as it normally occurs. Next slide, please. So, from that same source, we have pregnant women are anemic. But should they be? The answer is no. In this micrograph, you look at the right. The right is for pregnant women compared to the left, non-pregnant women. If you look at both, you can see that what makes them to become anemic, as it were, in quotes, as it were, is not the pregnancy, but due to some nutritional problems, as it were. So a pregnant woman can be deficient of certain nutritional values that could help her to respond to the plasma expansion by making more red cells. So when a pregnant woman is lacking of iron and other nutrients, of course, the red cell expansion that's expected to follow each pregnancy is going to lag far behind the plasma expansion, leading to anemia of pregnancy. In which case, given what is lacking in this group of persons, is going to improve the clinical outcome, both for the pregnancy and for the woman. That's why some countries have fortified food for pregnant women, or they give it as routine in the antenatal exposure. Next slide. This is what I've already shared already. Next slide. That's for the preschool age, which is very stable. So what we are seeing is that the hemoglobin drops from the first trimester due to dilution. By the time the woman gets to the second trimester, the rate of increase of plasma has started stabilizing, and the red cell mass begin to increase, leading to a picking up of the hemoglobin level at this stage, leading towards the time of birth, and the woman can deliver normally. Next slide. This can happen in a pregnant woman, just as what we've seen in the previous iron deficiency state that we presented. Next slide. So nutrients can be lacking, and if provided for the patient, for the woman, I almost always say patient all the time. A pregnant woman is not a patient; she's a client because she's not sick. It's a physiological state. Would you normally transfuse, or you look for the cause of the anemia and correct it for the patient on time? Next slide. So there are other forms of causes of anemia, and that is infiltrative myolopathies. It used to be called myelopathic anemia, whereby other agents or pathologies in other parts of the body can infiltrate the marrow, the site of hemoglobin red cell production. Tuberculosis, cells from solid tumors or even leukemic cells, Gaucher cells, malaria parasite, lymphoma cells, all can invade the marrow. And once this happens, the mechanism of cell production in the marrow is shut down. What happens is that it's only when the cause is treated and the pressure in the marrow is relieved that you can see a rational cause in managing such anemia. So how do we, for instance, in malaria, there's a real depression of the marrow even after anti-malarials have been given. The breakdown product of the malaria parasite serves as a problem for red cell production in the marrow, leading to different kinds of abnormal cells that are being produced, that is plastic cells, during malaria infestation. At this level, it would be wise to say that the best thing to do is, if we are able to take time to find the cause, treat the instigating cause, and see the anemia here improving in the patient. Next slide, please. So, would you transfuse all your patients with malaria? In young children, if the cause is sought for on time and treated, they usually do well. Next slide, please. There are other bone marrow failure syndromes, aplastic anemia, Fanconi, pediatric MDS, and Pearson syndrome. There's a lot more that will present with anemic state. But even in this, some of them, just virtually no one can, little one can do to change the outcome. except, for instance, bone marrow transplantation is done in order to either prolong life or to remove the main problem. Next slide. Now, in septic state, when there's an infection, there's a problem with oxygen delivery to the tissue. Because sepsis will actually alter the intracellular calcium milieu. It will reduce the ATP in the environment. And it will also reduce nitric oxide in the system. The membrane component of red cells is also destroyed, especially the salicylic acid. And what helps in adaptation is an increase in 2,3-DPG, which favors releasing oxygen to the tissues where it is needed. This happens as a response to sepsis. Now, during sepsis, white cells, in an attempt to contain the infection, get damaged, and reactive oxygen species are released, and it also cause damage to the red cells, causing a lot of problems that will worsen the anemia, just as the body is taking steps to also improve the anemic state, or at least help the patient to survive all this. Even the variations in temperature we see in the oxygen distribution curve comes to play in order to help the patient to survive a septic state. Suffice to say that once there's an infection, there is a disturbance in the delivery of oxygen to the tissues. And this has to be taken into consideration, especially in children or patients with the chronic obstructive airway disease. It has to be taken into consideration in the way to combat the problems. Thank you. Next slide. So once anemia starts, the response will depend on the rate of onset of the anemia. If it's rapidly occurring, like in a bleeding patient or in a surgical state, of course, there's going to be a massive response to that anemic state. But there are two outcomes. The patient responds and is able to halt it and survive, or the patient responds and is not able to and will need assistance. What do we do? Like in surgical state, the patient is bleeding. Do we pour more blood inside as in transfusion, or look for ways to stop the bleeding? The extent of hemoglobin drop, if it is gradual, adaptations takes place. The degree of drop of blood volume, like I've just said, if it is drastic, of course, the body will respond, but the best is to stop the loss of blood volume. In whichever happens, the cardiopulmonary compensation takes place, increased stroke, cardiac output by increasing the heart rate and the stroke volume. And of course, the underlying cause is the best way to manage once the patient has been resuscitated and stabilized. Next slide, please. So you are going to see pallor. You're going to see skin and mucosal changes. There will be neuromuscular changes. Retinopathies will take place, and even in GIT there will be changes. It is customary to look at the mucosal membranes in children, in adults. Suffice to say that that does not give us a fair idea of the hemoglobin or even blood volume of the patient at the time we're examining the patient, because the pallor is starved of blood because of regional redistribution that takes place. The body redistributes blood to very vital organs like the brain, the heart, and the lungs for the patients to survive. Once this happens, there's going to be splendid removal of blood from the skin linked to the pallor, which is not going to give you a fair idea of what is happening. It's good to measure, as it were. Next slide. So, like in heart failure patients, iron has been implicated in patients with heart failure and gas exchange. And added iron has been found to be something that has improved clinical outcome. Next slide. You can see increasing hemoglobin by just 1 gram makes a lot of difference in oxygen concentration in this work that we've done by Patel and co. Next slide. One of the things that we saw in malaria patients, how the hematocrit begins to drop, continues to drop in spite of treatment. So if you look at the number of days treatment was started, and you look at reticulocyte count, which begins to drop and then begins to increase gradually as treatment goes on, and the treatment goes on, it goes high because at that rate, hemolysis is taking place. So as the hematocrit drops, so also reticulocyte, that's new cells are being made as new as the malaria cells are, malaria is destroying the cells. So also is the body trying to respond. Once the anti-malaria is working in this patient and hemolysis has been arrested, of course, the body responds by also halting the production of new red cells or reducing it as it were. This is an adaptation in a malaria endemic area. So in conclusion, it might be safe to say that the utilization of the physiology of anemia, pathophysiology of anemia in the human system is useful and a very important tool in clinical practice, which if well understood, if you look at the number of the pathogenesis of anemia that we looked at all through, especially in the medical aspect, a lot of them will not require any exogenous blood transfusion. A rational use of this knowledge will help us to manipulate the body's ability to respond and replace what is needed, and the patient will get well.